whole idea of a meeting like this is to introduce you to the specific types of people that you need to bring on board as part of your entourage and part of your team. The ability to have physicians who have world-class expertise in medical oncology and other clinical trials and other targeted agents, etc. So with that, it's a nice way to transition into our head of surgical oncology and a co-director of the melanoma research program here, Dr. Mark Faries. And Dr. Faries is going to take us through the ideas behind surgical assessment and where surgery can fit into your care from the initial diagnosis to the advanced setting and beyond. So welcome, Dr. Faries.
Thanks, Dr. Hamid. It's great to be part of this year's symposium. It's been a great series over the years and should continue that way for some time, I think. This year's format, I think, is a little hard to get used to. Certainly for me, it feels like sort of a how-to YouTube video. At the end of today's program, you should be able to remove small melanomas in your kitchen or crafting room. I do look forward to this year's meeting and the discussion, but very much look forward to being able to get together in person, hopefully sometime in the near future. So my task is to talk about the role of surgery in treating melanoma. And surgery should have a very prominent role because of the way that melanomas tend to present. All right. So melanoma is in the news in recent years. There are a lot of people that you know of that have had melanoma and have shared their stories across media. There are medical miracles that have been reported. And everyone, I think, is familiar with Jimmy Carter's story of having advanced metastatic melanoma that now has been fully treated. In the science world, there's been famous people created by this as well, with the developments of the immunotherapies that Dr. Memi was talking about, with the Nobel Prize a couple of years ago for the people that were instrumental in developing those therapies. And of course, it's with these new medications is big business as well. I was reviewing these slides this morning and felt just a little bit uncomfortable having Jimmy Carter and Diana Torres in such close proximity. So I may have to tweak that at some point. But in any event, most of this news is about the medical therapies that you've heard about and many of you have experienced. But most melanoma actually is treated surgically. Most patients, over 90%, will present with melanoma that's either localized to the site on the skin or is limited to that site and to the regional lymph nodes. And so most patients in those categories have surgery as the mainstay of their treatment. And for those patients, the outlook is very good. They often are cured with the surgery alone. So it remains a big component of the way we treat patients. And surgery has a role not only in the primary melanoma and the regional lymph nodes, but potentially also in metastatic sites in other parts of the body. And so I'll talk a bit about all of those areas where surgery can play a role. In terms of the primary melanoma, the melanoma on the skin, the concept for treating that is fairly simple. It's to remove the melanoma itself together with a safety margin around the outside. So if you think about the melanoma site, in the operating room, we measure a small margin from the edge of that, and that creates the excision that needs to be done. And then we use various techniques to reconstruct the defect that we've created with that excision. You can see that the excision is much bigger than you might have imagined based on the size of the small lesion that was on the skin. There are standard guideline recommendations for how much of that skin needs to be removed as a safety margin. And the width of the margin varies based on the seriousness, in this case, the depth of invasion of that primary melanoma. The thicker the more high risk the melanoma is, the wider the margin needs to be. The margins started out actually much wider than they currently are today. And so the first report of recommendations in terms of margins came from Samson Handley in Hunterian lectures at the turn of the 20th century in London. And he reported a handful of cases where it was actually fairly extensive, locally extensive melanomas with satellite metastases, and based his recommendations for margins on those findings. And that essentially established a 5 centimeter margin as the initial width of excision for all patients with melanoma. But those margins were some subject of controversy over the ensuing century. And by 1970, there were various recommendations for margins, the narrowest being about 2 centimeters, but then a large number of experts recommended 5 centimeters, perhaps 8 centimeters or 15 centimeters, or even as wide as possible. And you can imagine there would be a decent amount of morbidity, of side effects and complications that might go along with excisions that were routinely that large. And so, as we've done in other areas of medicine and in medical treatments for melanoma, there are a series of randomized clinical trials that were done to try to narrow those margins and keep the excisions safe at the same time. And the different trials addressed melanomas of different thicknesses. And they started with trials of relatively thin melanomas, 2 millimeters or less, but also then included in subsequent trials patients with intermediate thickness and thicker melanomas. And so through these series of trials, that 5 centimeter margin was narrowed to 2 centimeters for the thinner groups and 2 or 3 centimeters for the thicker groups. And then additional trials led to even narrower margins, so that thinner melanomas now generally can be treated with a 1 centimeter safety margin. And there is now an ongoing trial that we're participating in to see whether even those thicker melanomas can have the width of the margin safely reduced. That trial, which has been championed by Mark Moncrief in the UK, and also now being led in Australia by Michael Henderson, enrolls patients who have relatively thicker melanomas, so stage 2B or worse, and they're randomly assigned to either having the current standard 2 centimeter margin or a narrower 1 centimeter margin, and we'll be following those patients for their outcomes over time and quality of life, surgical complications, and those sorts of endpoints to see whether or not 1 centimeter can do just as well as 2. And we're enrolling patients in that trial now at the Angeles Clinic, and they're being enrolled around the world. So hopefully we'll get to that answer as well. What about lymph nodes? Lymph nodes are often a big topic of conversation when someone's first diagnosed with melanoma. And what are lymph nodes? So lymph nodes are small immune organs, more or less, that are collected in clusters in various parts of the body. And their job is to survey the fluid that's in our tissues, not the fluid that's in the bloodstream, but the fluid that's in the tissues that passes through these lymphatic channels and flows from the peripheral tissues into these lymph nodes. And then the lymph nodes are supposed to look for signs of infection or foreign bodies or other things to generate immune responses to. But those same channels are the path of least resistance that the melanoma cells can travel. And so they're an important route of potential metastasis that we need to evaluate. The lymphatic channels in the skin, you can see they're highlighted by the blue dye that we inject at the time of a sentinel lymph node biopsy. You can see those little channels, and they're all throughout all of our tissues. And then they coalesce into larger channels and pass into lymph nodes like the one you see on the right that are the site of potential spread of the melanoma. Lymph nodes have a long history of melanoma as well. So actually the first case reported in the English literature of melanoma by Hunter was preserved in the museum in London, in the Hunterian Museum in London, and it's actually a lymph node, not a primary melanoma on the skin. So lymph nodes have been recognized as an important component of melanoma progression for a very long time. And the controversy in treatment is how and when do we address lymph nodes with surgery? Do we do it up front before we have any indication that there's something that has spread there? Or do we wait and only involve the lymph nodes in surgery if there's something that turns up there we can see on a clinical exam or a scan? And so the melanoma can spread to the lymph node. It can spread from there to other sites or potentially to the rest of the body. So it was proposed very early on that all of those regional lymph nodes be removed at the time of diagnosis of the melanoma on the skin before we had any reason to believe there was something there. And that was proposed by Herbert Snow, who was a surgeon in the London Cancer Hospital, now the Royal Marsden. And he published in The Lancet over 100 years ago a proposal to do what he called anticipatory gland excision, what then came to be known as elective lymph node dissection for all patients with melanomas on the skin. So removing all of the lymph nodes from the area where the melanoma was, even though you didn't have any indication from the outside that there was anything wrong with them. That obviously led to a decent amount of morbidity of complications from those moderate-sized operations to take those lymph nodes out. And over the years, that was a subject of quite a bit of controversy. Don Morton, pictured here, was instrumental in revising the way we treat lymph nodes for a more sort of rational approach and developing the sentinel lymph node biopsy technique, which is now a standard that we use for patients, selected patients with melanoma. And it was initially developed with scans in which they injected radioactive gold particles at the site of the melanoma to see where the lymph nodes were that drained from there. And then eventually that led in a progression and an evolution of technique to the sentinel node biopsy. And so the way that works, the way the sentinel node biopsy works is we can map the lymphatic drainage from where the primary tumor site on the skin is through those lymphatic channels to the particular lymph node, the sentinel lymph node that is receiving direct drainage from that site. And we do that by injection of a couple of different types of tracers, a blue dye and a radioactive tracer at the skin site, and then making a little incision over that sentinel node and removing the sentinel lymph node. The rest of those lymph nodes then can be left alone and only were considered for an intervention if we found melanoma in that first lymph node. If that lymph node was okay, then we could safely assume that the rest of the lymph nodes in that area were okay as well and could be left alone. So that spared a lot of people the larger operation. That technique, the sentinel node biopsy, was put through a large clinical trial, the multi-center selective lymphadenectomy trial 1, which indicates that there's another one coming up. But that trial randomized patients with melanoma on the skin to have either just a wide excision done or to have that done with a sentinel lymph node biopsy at the same time. The patients that had their lymph nodes observed initially underwent full dissections when they developed recurrences in their lymph nodes, if they did later on. And the patients who had a positive sentinel node, who had melanoma in the sentinel node, had a dissection at that time. Otherwise, they went on to observation. The trial didn't show a statistically significant survival benefit for the sentinel node biopsy technique. You can see that it's a little better, but it's not a significant difference. When we looked specifically at the people that had melanoma in their lymph nodes, there did seem to be a big advantage in taking that disease out early rather than late. But for various reasons, that's something of a controversial observation. And we could talk about that for probably an hour. But whether that's a real difference or not wasn't enormously relevant because of the other values of the sentinel node biopsy. The main one was determining the outlook for that patient. So if the sentinel node was clear, the outlook for the patient is much better. The risk of a recurrence is much lower than if we found melanoma in that first node. And that has had a big impact on the accuracy of the information we can give patients when they first present with their melanoma. So this AJCC is the group that tells us what factors we need to look at to say what the risk of recurrence or death for melanoma is for any given patient. And these are the stages of melanoma that you've heard of. Before sentinel lymph node biopsy, when we would tell patients that they had stage 1 or 2 melanoma, that is melanoma that was localized to the skin and hadn't had any indication of spread, actually a decent number of those patients over time did develop recurrence and were at risk for dying of melanoma, despite our feeling that their lymph nodes were negative. With the inclusion of the sentinel node information in the staging system, we now are much more accurate at telling the patients that have clear lymph nodes that things actually look pretty good, and also being able to identify patients who do have spread, who might be candidates for additional treatment at an earlier time point. And so this is one of the main reasons why sentinel node biopsy is part of the standard treatment we do for many patients with melanoma, depending on the risk that goes along with their initial disease. So the next question, once the first MSLT trial was done, was do we need to do a full lymph node dissection? So for patients who had melanoma that spread to that first lymph node, once we've taken out that lymph node and the melanoma on the skin, do we have to remove the rest of the lymph nodes in the same area, which is what the standard was when the technique was developed? So to answer that question, we devised another clinical trial to try to determine whether the advantages of taking out those other lymph nodes outweighed the disadvantages. And the disadvantages are having a bigger operation. And in most instances, those other lymph nodes that are taken out actually don't have any melanoma in them. And so a clinical trial was designed to answer that question as well. And in that trial, patients who had melanomas that had metastasized to the sentinel lymph node were randomly assigned either to have what was at the time the standard treatment of taking out the remainder of the lymph nodes, a completion lymph node dissection, or to be followed with ultrasounds of their lymph nodes in addition to clinical observation, and only had intervention if they developed a recurrence in the lymph nodes over time. That trial showed that the two options for the patients were really the same in terms of long-term survival. There was no hint of a benefit in terms of survival for taking out the rest of those lymph nodes. There was another similar trial done at the same time by the German melanoma cooperative group that showed very similar results. And so at that point, the standard of care was changed, and patients no longer had to have this full dissection done at the time of their initial sentinel node diagnosis. The other thing that we learned was that, in fact, you get good regional control of the metastatic melanoma with just the sentinel node biopsy. And so this plot shows how many patients had disease in lymph nodes beyond the sentinel lymph node over time. And with the completion dissection group that you see there, you can see the vast majority of them never have any problem in the rest of their lymph nodes. But even in the group that had the rest of their lymph nodes observed, so they didn't have more surgery, 3/4 of them never had a recurrence in their lymph node basin. And so with just this outpatient lymph node biopsy procedure, all of the metastatic melanoma in their regional lymph node basin was taken out with that procedure, and they didn't have to have more of an intervention. So it's another potential value of the sentinel node biopsy itself to be able to achieve that level of control. So with completion dissection, these two trials show that it's safe to not do a completion dissection. You do lose a little bit of staging information, which might be important for a few patients, and you get a little less regional control, although as you've seen, it's still pretty good with just the sentinel node biopsy itself. Does anyone still need a completion lymph node dissection? I can tell you practically very few people elect to have that done. There may be a handful of patients potentially who can't be followed for one reason or another, who might have a lymph node dissection done at the time of their sentinel node diagnosis, but for the most part, people can avoid it. And so over time, we've had a progression in terms of how we treat lymph nodes from the time of Snow, when he recommended that everyone have a lymph node dissection, to the elective lymph node dissection era, when we were able to spare about half of the patient's consideration for that procedure, to the MSLT era, where we can know that patients have negative lymph nodes and don't need the dissection, to the current era, the post-MSLT2 era, where it's really a narrow sliver that ends up having lymph node dissections for metastatic melanoma. I'll skip this in the interest of time, but we are developing techniques of improving the lymph node dissection itself so that it's less morbid with minimally invasive procedures where a large incision is not used, but we use the small instruments that we use to take out appendixes and gallbladders now to do the lymph node dissection with less side effects and morbidity. But getting on to metastatic melanoma, that is melanoma that's spread beyond the lymph nodes, does surgery have a role there? In the past, when the medical therapies were not so good, we saw that with just surgery in selected patients, we could achieve long-term survivals of 40 or 45% potentially with appropriate selected patients who really just had surgery as an effective therapy. That era has changed. As you heard from Dr. Memi, we went from an era where we had DTIC or interleukin-2 to an explosion of much more effective agents that now are available for metastatic disease. We looked just a few years ago at patients in the modern era who had surgery and systemic therapy for metastatic melanoma. And the group that had surgery did a bit better. But as you can see in this lower group, in the lower plot, the red line are patients in the modern era, and the blue line are the patients in the former era. And you can see there's been an enormous advance with the improved treatments that you've heard about in terms of how people do over time. But even in that era, we looked at patients who received one of these newer medications, a checkpoint inhibitor or a targeted therapy, and compare people that had that with resection or that or the systemic therapy, only matching for characteristics between the patients, and there did seem to still be an advantage to surgery. And then a last interesting thing to share is work that's been done by Danielle Bello and Charlotte Arian and our colleagues at Memorial Sloan Kettering, where they looked at patients who had received surgery in the setting of checkpoint inhibitors, that is the ipilimumab or Yervoy, or the nivolumab or pembrolizumab. And they divided patients up into how they had responded to that treatment before their surgery, and whether they had progression at multiple sites, whether they had responding lesions or stable lesions that were taken out, or whether they had isolated set areas where there was disease progression and they had surgery to address that progression. And what they found was that the people that had surgery to clear up a last bit of tumor that hadn't been fully responding to the systemic therapy in the red line do extraordinarily well, amazingly well. The patients that had a progression of their melanoma at multiple sites did not do as well and potentially didn't benefit from the surgical intervention. And then the group that had most of their disease under pretty good control with the systemic therapy, who had surgery as a way of helping that, an adjuvant surgery basically to help that systemic therapy, did quite well as well. And they found when they had patients that had that situation where all of the disease was taken out surgically, they had very good long-term outcomes. So I think this is encouraging that there'll be interaction between surgery and systemic therapy that'll increase as time goes on. So for primary melanomas and lymph nodes, the surgery has become less invasive and more accurate. And there'll be interesting developments, I think beneficial developments in metastatic melanoma with the role of surgery evolving over time. So I want to thank everyone who's attended today. Great to have you with us. I wanted to also thank all of the investigators and participants in the MSLT trials, particularly Don Morton, my mentor, and then the fellows and collaborators who have helped with the research over time, and recognize our funding sources as well, the National Cancer Institute, the Department of Defense, and the John Wayne Cancer Foundation. So thank you all very much for attending, and I look forward to the question and answer session.